Hey, it's your old pal Dr. Steve, and welcome to the SARS-CoV-2 COVID-19 updated situation report for April 19, 2020. This is the fifth in a weekly series. Previous episodes are available, and some have general information about the current pandemic that are not covered on a weekly basis, so check them out. Okay, let's get started with the current statistics that we are following today. So here we are at day 89 since the WHO has started looking at cases. As of this morning, we had about 600,000 cases plus change, 32,000 new cases over the last 24 hours. And we're still sitting at less than half of 1% of people in the United States that are infected that we know of. Now, we still don't know what this asymptomatic number is. If it's 1 for 1, then we've got about 1.2 million cases. But what if it's 10 to 1 or 100 to 1? We will see very soon. I think there are some studies that are being done to look at the percentage of asymptomatic cases. We have some idea, and we're going to talk about one in the very last slide today. But that number is crucial to eventually know. We will only know that number once we have very robust testing where we're testing people not just because they're sick, but just because they live in this country. So when we have that sort of massive screening, we'll get some ideas. Here's a graphical representation. You can see that the United States numbers have attained sort of this linear curve, which means that they're increasing linearly rather than exponentially. And China had this leveling off, and then they've had a linear increase and then a little bump, and now they may be leveling off again. We'll see. Next week we should have a better picture of that. And Italy not only went through this linear phase, but you could still sort of see that this thing looks like it's just getting ready to level off, and a slight S-curve that we don't quite have yet. Here's the epidemic curve from last week that showed some leveling off in Europe and sort of choppy data in the Americas. And here's this week showing continuation of this leveling off. You see this periodic change here that's got to be, in my estimation, due to reporting. So you really want to just sort of average that out, and that looks like a curve like this. And the same thing here. You can see the same sort of choppiness to it. So we'll level this off. This looks like in the Americas starting to level off. And in Western Pacific, they had this sort of peak and then still smoldering in that area, and increase in cases in Southeast Asia. Look at the new case detail. Here are our 5-day and 20-day moving averages. If you don't know what those signify, feel free to check out the previous COVID SITREP, where we discuss this in detail. But you can see for the first time since this thing started that the new cases dipped below the 20-day moving average. Here's the 20-day moving average. At no time did the cases dip below that, so that's a good sign. Although over the last couple of days we've seen this secondary peak. These things, as we've discussed, are lagging indicators. They don't tell us where we're going. They tell us where we are and where we've been. So that let's just say everyone gets excited about this and just says to heck with social distancing. Well, tomorrow these numbers could be up here or in 5 to 7 days. So this is a good sign that our mitigation efforts are bearing some fruit, but we have to continue them. And we're going to talk about the phases of reopening in just a second. This is the Bollinger Band analysis, and you can see that the upper band and the lower bands are getting closer together, which means that the data is less choppy. That's really all that means, because these are a function of the standard deviation. But you can also see that the red new cases are still peeling away from the upper band, although this last data point showed it getting a little bit closer. The next week will really tell the tale. What we're really hoping to see is this whole construct start to decline. Still comparing to influenza, we've got 665,000 cases, known cases of COVID-19 in the United States as of today, and up between 39 and 56 million cases of influenza. These are estimated numbers. These are known numbers, so you really can't compare the two. What we can compare is the deaths, and right now COVID-19 deaths are comparable to influenza deaths in this country. But the influenza epidemic should be winding down, whereas the COVID-19 epidemic is still doing its thing. So we'll see what those numbers do over time. Testing, we're up about 1 million tests in the United States this week. We are by far in the United States testing more people on an absolute number basis than anywhere else that I could find data on. However, on a per capita basis, that's still not the case. Italy is outpacing us significantly on a per capita basis. And United States and South Korea are right at the same data point, but you can see South Korea leveling off and the United States still increasing. So it'll be some time before the United States can overtake Italy. We're testing more per capita than the United Kingdom and Japan right now. Now, here's Italy, United States, United Kingdom, Japan. Here they are again, way down here. This is that same graph, but now I've included Iceland, where Iceland has decided that they're going to test more people per capita than any other country in the world. And I'm hoping that we will get some awesome data out of that testing effort very shortly, particularly with regard to asymptomatic percent of the population. So, til hamingju Iceland. Congratulations, Iceland. It's awesome. So the reopening plan was unveiled this week, and I thought we'd just run through it. There are these things called gating criteria. So before you can even start on phase 1, you need to pass these gating criteria. And then to go from phase 1 to phase 2 to phase 3, you must also go through these gating criteria. So they are 2-week data sets, have to be met before moving to the next phase. There has to be a downward trajectory of symptoms and cases over the last 2 weeks. I'm making this very simple. It's a little more technical than this, but this gives you the sort of the gestalt of it. And the cases can be percent of positive tests versus total tests. For example, you may see your total cases going up, and that's because you're testing more. So you don't want to exclude that population from maybe being reopening if what you're noticing is a decrease in the percentage of positive tests compared to the number of total tests. And so this corrects for that sort of bias when you're testing more and finding out more people are turning positive. And your hospitals need to be not overwhelmed at the time. If they're overwhelmed, you're staying in that phase. Once they get less overwhelmed, then you can consider going on to the next phase. You have to have this sort of core preparedness. You got to be able to screen, test, and do contact tracing. We talked about that with regard to Singapore. Now, I talked a lot about Singapore last week as being sort of a model that we can use. And then, of course, now Singapore is on lockdown quite a bit more significantly than they were before. It doesn't necessarily mean that their model is flawed. What it means is that when you reopen or allow yourself to stay open, you got to be ready to lock it down if things start to even show any sign of reversal. So, and that's built into this reopening plan. But you, like Singapore, we need to be able to contact trace. So if you come down with symptoms and you test positive, the ability to go find all the people that you came into contact with over the previous X number of days and get them to go into isolation or test them for antibodies if that's appropriate and allow them to go on their merry way. is absolutely essential. Without that, we can't get anywhere. You have to have no shortage of personal protective equipment for healthcare providers. You have to be able to provide ICU beds if there's a surge. So if you're already at capacity, you can't move on. You're not meeting that criteria for core preparedness. And you need to be able to detect and mitigate any rebound. So if you start to rebound, you got to be ready to go backwards. And in that case, you would either restart your phase or you may have to go back to a previous phase. And then individuals have to be able to practice good hygiene, and they need to stay home if they're sick under any of these phases. Okay, so phase 1, vulnerable individuals, shelter in place. Those are people at high risk, people, the elderly, people with immune problems, diabetics, etc. When you're in public, you have to social distance and avoid groups of greater than 10 people. Minimize non-essential travel and follow all CDC guidelines regarding post-travel isolation. And then people are to return to work in phases, and employers are still to encourage or basically mandate working from home through internet connection, and but they'll allow people to come back in phases and close all common areas, so you don't want people congregating. Schools would remain closed during phase 1, and some venues could be open, but only with strict social distancing rules. This would be restaurants and places like that. And bars would remain closed, and gyms could be open, but with very strict rules for hygiene and social distancing. And then outpatient elective surgery would be okay. If after 2 weeks of that you're still showing declining cases, as we discussed in the core preparedness and in the gating criteria, then you could go to phase 2. The vulnerable would still shelter in place, but you could avoid groups of greater than 50 people. Non-essential travel can resume. Telework is still encouraged, and schools can reopen. Nursing homes would continue to ban visitors in phase 2, but inpatient and outpatient elective surgery would be okay, and venues would open, and even including bars, but with precautions. And the big thing with bars is you don't want people standing up against the bar all clustered trying to get a drink. So they'll have to have a plan to mitigate that. Then in phase 3, vulnerable individuals can re-enter but practice social precautions. You'd still avoid crowds, but no limit on the numbers of crowds or the number of people in crowds. But you would resume unrestricted staffing at most workplaces, and visits to nursing homes could resume, and large venues would open, but with limited physical distancing, including gyms and bars. And then we won't hit phase 4 until this thing completely burns out, and or we have herd immunity, and or a vaccine or a treatment that keeps people out of the hospital that we would treat in the early phases of the disease. So speaking about that, let's look at coronavirus drug update. For this week, I want to just focus on Remdesivir. Remdesivir is a drug that has been created by Gilead Laboratories, and they have 2 phase 3 clinical studies in the U.S., and there are 3 phase 3 studies elsewhere that I'm aware of. These are randomized, open label. That's the only problem with these. They're open label, but that's the way to get this stuff done quickly. But when you don't have a blinded study, it makes bias a little bit easier to creep in. Now, it's multi-center, so if there's bias in one area, you hope that there won't be bias in other places and it'll cancel out. But adding a placebo arm to this would have been okay if you just, and people will say, well, it's not ethical to do a placebo control. Well, they're comparing this to people who are not taking Remdesivir. That's how they're going to compare this to people who got quote-unquote standard care. And hopefully they will match those people pretty well so that we get decent results. But if you're going to match them to those groups, why not in the institutions where you're doing it, just give everybody a Remdesivir placebo bag. because this is an IV medication. It'd be cheap to do, cost a couple of bucks. And then you would have a placebo arm that's not really the people wouldn't be randomized to placebo. That would just be part of standard treatment. And then you would have the people who are actively treated. Nobody know who they are until the end of the study. It would give us slightly stronger data. That's all it is. But this will have to do, and we'll see when we interpret the results. Study 1 looks at 5 and 10-day dosing for severe manifestations of disease. And study 2 looks at 5 and 10-day dosing for moderate manifestations. So the way they define moderate disease in the study is hospitalized requiring medical care. So these people already been hospitalized, and that their oxygen saturation is normal on room air, which in that case, why are they hospitalized? And X-ray evidence shows lung involvement. So they plan to complete this in May 2020. There might not be a whole lot of people that meet this, but over the whole country, we only need 1,000 to 1,600 people. And again, as I said, their comparison cohort is standard care. So we'll see. This is the study I'm interested in, or I'm less interested in the study that is looking at people with severe disease, because you've already waited too long. Why should we wait for people to be on the ventilator before we treat them with this stuff? So the earlier we can treat them, the better. And so the next study needs to be done on people somehow before they end up in the hospital. Let's talk a little bit about remdesivir. What I'm aware of is the IV preparation. No clue whether this can be given orally. A lot of medications like this that look this way can't be taken orally because they're broken down by the GI tract, but there may be a prodrug that could be given in pill form that would then cleave to this. So this is remdesivir, and this is adenosine. Okay, so adenosine is made up of two components, adenine, which is this section here, and ribose. Okay, so adenine is one of those molecules that RNA uses to create itself. Just leave it at this, that this section here is part of RNA, and this is one of 4 base pairs that viruses can use, RNA viruses can use to reproduce themselves. Okay, now here's remdesivir. Look at this now. This section looks a whole lot like this section, doesn't it? And when this is given, this part is cleaved off, and now all of a sudden you have a molecule that looks very much like adenosine, but it's not. And when you incorporate this into your RNA, it will cause the RNA to stop forming, and because the next base pair can't attach to this. So it's pretty awesome. The stupid virus will incorporate the remdesivir into its RNA instead of the adenosine, and it causes disruption. So here's how it works. Here's the SARS-CoV coming in. It attaches to this receptor, these ACE2 receptors, through the spike protein, and now the cell membrane merges with the viral membrane, and then you've got this viral polymerase protein that is translated by the cell's ribosomes, and then this comes down and oops, it's trying to make more RNA, and then this remdesivir, the active portion of remdesivir is called GS441524. Don't worry about that. But the drug comes in and blocks that, and it inhibits RNA replication. So suck it, COVID. All right. Anyway. More on that when we get data. We should have data in May. I don't have a whole lot else for you today. We can discuss anything. If you have any questions, definitely email me at weirdmedicine@riotcast.com. We're going to have a massive increase in testing this week. Some states are readying themselves for phase 1 reopening. There is a major longitudinal study of 5,000 healthy patients in California to determine the extent of asymptomatic immune patients. What they're going to do is just test these 5,000 people and then test them over time. That's why it's called longitudinal. And They're going to look at how many of them get sick, how many test positive, and how many people are asymptomatic. Another ship has been infected, and we have some pretty robust data there as well. 600 crew members on the Theodore Roosevelt. Thank you for your service. Is an aircraft carrier. 350 of those were totally asymptomatic. Now, these are generally young, healthy people. So it is interesting that about 60% of the people who tested positive were totally asymptomatic. So more on that when we get more data. Stay healthy. Stay isolated for now. Wash your hands. Soap is always better than gel. Wear a cloth covering when social distancing is difficult, like the pharmacy or the grocery store. Check out our Twitter at Weird Medicine. Podcast at riotcast.com/weirdmedicine or on iTunes and on SiriusXM on the Faction Talk channel, 8 p.m. Saturdays, 5 p.m. on Sundays, and on demand. Until then, see you next week for the COVID-19 situation report from your old pals at Riotcast, the Laugh Button,